أهلا وسهلا فيكم وكل حلقة وأنتم أغنى. للأسف لليوم العلم ما كان منصف مع المرأة، خصوصا لما يجي الموضوع لصحتها وراحتها الجسدية والنفسية. مع أنه نحن تقريبا وصلنا على المريخ، بعدنا لهلأ ما عنا علم كافي ومركز عن صحة المرأة، ونتيجة هالشي صار في سوء فهم كبير لكتير نساء، خاصة بعمر معين، وكأنه المشاكل الجسدية والنفسية اللي عم بيمرقوا فيها ما إلها حلول. كل هيدا لأنه لفترة طويلة كانوا بيعتقدوا أنه العلم يلي بينطبق على جسم الرجل هو نفسه بينطبق كمان على جسم المرأة. بس اليوم والحمد لله بلشنا أخيراً نشوف أبحاث جدية عم بتحاول تفهم، تعالج وتخفف من أعراض ومشاكل المرأة. المفاجأة أنه كتير من هالمشاكل لما راقبها العلم طلع أنه جذورها بتبدأ بالتغيرات الهرمونية اللي بتمرق فيها المرأة خلال مراحل حياتها. معي اليوم لنفهم أكثر ولنرسم خريطة طريق لكل امرأة عم بتفتش عن المساعدة. معي الدكتورة نور الحميدي، وهي طبيبة ومؤسسة لايف ستايلز باي نور. نور كرست شغلها وبتكرس شغلها لدعم النساء مشان تعيش سيدة بتوازن، بطاقة وبوعي بكل مرحلة من مراحل عمرها. من الكويت لأمريكا ومن الطب التقليدي للحلول المتكاملة، الدكتورة نور جاي تحكي بصراحة وبتفهم وتفتح قدامنا أبواب كانوا مسكرين. إذا كنتي عايشة أعراض ما عم تفهميها أو إنك عم بتحسي حالك مش أنتي، هاي الحلقة لإلك. دكتورة نور، أهلا وسهلا فيكي وشكرا جزيلا لحضورك معي اليوم.
أهلا وسهلا، مشكورة. I'm honored to be here. سعيدة بوجودي. How can I help you?
يا أهلا فيكي دكتورة. أنا بعرف إنه أنت بتحكي عربي، بس يمكن صعب عليكي لأنك صار لك فترة طويلة برا تحكي الأمور المهنية بالعربي، فرح نحول على الإنجليزي. Thank you so much then for coming to see us. Let me start by asking you about that study that really turned the tables and really sent a lot of women running out the doors and even windows. In 2002, the study was conducted, which basically concluded that women who were taking hormones to replace the hormones that naturally left their bodies as they aged were opening themselves up to cancer. The study was later proven to be wrong, but the effect of that stays with us until today. So what was that about really, and how much truth is in it?
So the study was called the Women's Health Initiative, and it was done here in the US. Really, up until the mid-90s, it was very well accepted by doctors that HRT, or menopausal hormone therapy, so taking hormones, was beneficial. Yani they felt that it improved our risk of a fracture, breaking our hip. They felt that it improved our risk of dementia. They felt that it improved our risk of heart disease. So the NIH, which here is the National Institute of Health, which is a federally funded large organization that runs these big studies, got involved in the late 90s, and they created a study called the Women's Health Initiative. They recruited 16,000 women. So it's really one of the biggest studies like that ever done. They recruited women in two groups. One of the groups had their uterus, so rahim, so they had their uterus. The other group did not, so they had a hysterectomy for whatever reason. And that's important because when we use HRT, when we treat a woman that has her uterus and we give her estrogen, we also must give her progesterone. It's really important that we do both to protect her uterus. So in a woman that does not have a uterus, you can give her estrogen alone. Okay, so that's why we had these two groups. Now, it's important to know what they gave them. They gave them Premarin, which is actually estrogen that comes from the urine of horses, okay, orally.
And I remember that. My mom used to take it.
Premarin, it was one of the first HRTs available, So it was Premarin that they gave them orally, and they gave them medroxyprogesterone, which is actually a form of contraception. So it's actually a drug that women took to stop getting pregnant, but it's like a progesterone on the uterus, on the rahim. So it gives them that protection. So they gave them Premarin, and this medroxyprogesterone acetate. And then for the other group, they gave them the Premarin alone. They had a control group and they started the study. Now, in 2002, they called a press conference in Washington, D.C. in front of the world's press, and they said the words, estrogen causes breast cancer. Now, of course, that resulted in, it was all over every news outlet, all over the world. It was on the cover of Time and Newsweek and all the major newspapers all over the world. Women stopped taking their HRT en masse. Millions of women across the world stopped taking their hormones. 9 days later, they published that data in the Journal of the American Medical Association, JAMA, which is one of our biggest, medical journals in this country. What they actually showed was in the women that received combined hormones, their risk of breast cancer appeared to increase by 1 in 1,000. So from 4 in 1,000, which is very low, to 5 in 1,000, which is also very low. And that increase was what we call not statistically significant. So when you do any study and you look at the outcomes, you need to prove that that couldn't have happened by chance. And they did not prove that that couldn't have happened by chance. Additionally, in the group that only received estrogen, so just the Premarin, their risk of breast cancer went down by 24%. Now that was in the data that was published 9 days later. So the data that was published 9 days later did not show what they had said 9 days prior, did not show that hormone therapy increases the risk of breast cancer. And unfortunately, the megaphone with which they said this, everybody just believed this. It's in the water. Ask anybody on the street, what do you think of HRT? And they'll say, well, no, I can't take HRT. It causes breast cancer. So unfortunately, that data was misrepresented. So that data has not changed over time. It's just that people are trying to dig it out and actually show people that what they said was not true. So hormone therapy does not cause breast cancer.
So why was this myth, which was propagated by that false announcement from the research, not the research, but the announcement from the research, why was that not busted? How come it actually continued to scare women for the longest time?
That's a really great question. To talk about the researchers, there were a couple of lead researchers that were involved in this study that 10 years before had said things like, we need to stop this HRT bandwagon. HRT causes breast cancer. So they came in with preconceived notions that women shouldn't take HRT. And they therefore made the data look basically how they wanted it. And if you read about this, there's a couple of books really talking about what happened in the WHI and how that publication, how that was published and that announcement came about. And it was basically a couple of rogue researchers that went rogue, that they in themselves believed that this before they even did the study. And then unfortunately with the world's media, they never, they propagated this announcement, but nobody ever really looked at the data. And the people that did look at the data and were trying to kind of get onto the world's media to try to explain this were quieted.
Okay, but now let's leave that in the past, because we really want to get over that, and we really want to get to a point where women take charge of their own wellness and feel good throughout their lives, not just for the 30, 40 or 50, first 30, 40, 50 years of their life, but for the next 50 years as well. But before we talk about what menopause is and what the symptoms are, etc., I wanted to, from the outset, bring up the counter argument about taking HRT, which is, well, our bodies naturally are losing those hormones. That's nature's way. Why should we get in between? Why should we get in nature's way? Why do we need to replace something that nature dictates that we start losing?
That's a great question. So the first thing I will say to that is, you don't have to take HRT. Everybody, that's not what we're saying. We're not blanket saying all women, when they go through menopause should take HRT. What we're saying is the following. If you think about what menopause is, it's basically the point in time at which we run out of eggs. So we are now outliving our ovaries. 120 years ago, the average life expectancy was in the mid to late 40s, probably 50, maybe early 50s. So actually, we were not outliving our ovaries. But with the advent of vaccines and antibiotics and appropriate nutrition, we are now we've added 20 to 30 decades, 2 to 3 decades onto our life that we didn't have before. So now we're in a situation where we're outliving our ovaries, which wasn't the case before. The problem with that is that when we outlive our ovaries, changes start to happen in our body, and we start to increase our risk of certain chronic diseases. And unfortunately, those chronic diseases lead to poor health span. So maybe we're well until we're 60, but then we're starting to develop chronic diseases that unfortunately limit our independence and limit our mobility, and we can't do the things that we wanted to do. So what we're seeing is women are spending the last 10 years of their life with poor mobility, having to be in nursing homes, cared for by others, and with significant chronic diseases, and a lot of times pain, especially in those with osteoporosis. So what I'm saying is not that everybody should take HRT. I'm saying that not living without estrogen has lots of long-term implications for our health. And if we want to be the best that we can be, as long as we can, it's something we need to consider.
You know, Noor, I speak from personal experience, and when I discovered menopause, I have to say, when I discovered menopause, because they don't teach us about menopause as young women. They may teach us about periods, the onset of periods, but they don't teach us about menopause. And I actually discovered it was a revelation. It was like a puzzle that I put together for myself. I went through probably a decade of inexplicable symptoms and aches and pains, and I looked through Google until the cows came home, and I spoke to so many doctors and did infinite tests of all sorts. And then it was just putting one piece next to the other, and then stumbling upon a documentary that my daughter told me to watch, that I understood that all these symptoms put together is me going through menopause. And it was so surprising that why do we not have this information, and why do we need to discover it bit by bit is something that I could not really understand. Now, of course, education is very important, but when can education start? Let's define what perimenopause is, menopause, and postmenopause.
Okay. So if you look up the word menopause in Webster's Medical Dictionary, we love to define things in medicine. It actually gives a definition of menopause as the point in time at which you are a year without a period. Now, I find that definition very problematic. It ignores a woman's experience of menopause, which actually starts long before the final period. It also creates a line in the sand, like, oh, when you're past this point, it's all good, you're going to be fine, or everything's going to go away, and it's not. So I think that definition, unfortunately, makes it about periods and not actually about the underlying shifts that are happening in our body. So I like to redefine menopause in the setting of my clinic. We redefine menopause as the point in time at which we run out of eggs. So we are different than males, and females are different. Males have the ability to make new sperm every day until they die, unless they're castrated. Females do not have that ability. We made all of the eggs for our lifetime when we were in our mother's uterus during the pregnancy that carried us. We made all of the eggs. So what you made was what you got for your life. That was it. There's no way later in life to make any more eggs. So your normal premenopausal body is when you've got plenty of eggs, you're ovulating, everything's working perfectly. Menopause is when you've completely run out of eggs. Perimenopause is when you're running out of eggs. So you've reached a critical threshold that you're not actually using as many eggs every month. And so your egg level is the amount of eggs that you're using every month is changeable. It's low, then it's high, then it's low, then it's high. And that results in a significant change in your estrogen pattern and a very low progesterone. And that's what perimenopause is. That's why we call it the zone of chaos.
And chaos it is. And a lot of the symptoms that vary from one woman to the other, or the symptoms that you are most aware of. I used to think that menopause was, just you sitting and fanning
Hot
yourself.
flashes. Yeah.
And I actually saw friends of mine, maybe a few years older, maybe different times in their life, who were doing that and who were bearing it and did not even think about going out and seeking hormone replacement therapy to make those symptoms better. But when we talk about symptoms, there are these instantaneous sort of symptoms, the discomfort of the hot flashes and so on, but they're nothing compared to the brain fog, for example. Nothing compared to the heart palpitations. And every single woman I know
Has heart palpitations.
of a certain age has been prescribed Concor by
Yeah.
yeah, and the doctors are not clicking on yet. Actually, the other symptom is the moodiness and the depression, feelings of depression. I had that, and I went to a psychiatrist and I sat with him in his office and he prescribed me the medicines, and I put me on them and then started increasing the dose, and I wasn't feeling too good on that. Tried to reduce it, and after I solved my puzzle, I went back to him and I said, I need to get off this now. And he says, but why? You're doing so well. I said, I'm not doing well at all. Look at me. Second, I know what it is. A year later, I went to him with my elderly mother, and he told me, Siba, I learned from you. Now I know to consider menopausal symptoms when women of a certain age come into my clinic with moodiness and depression.
I mean, there's been studies that have been done, Sibeth, showing that women see on average 5 to 7 doctors before they get a diagnosis of perimenopause and menopause. And one of the issues is, I think, especially in perimenopause, you mentioned hot flashes. 1 in 5 women will never have a hot flash.
Mm.
But a lot of times I find hot flashes is happening later. It's happening closer to when you stop having a period altogether. Whereas most of women's symptoms start long before that final period, especially the brain symptoms, the brain fog, the anxiety, the insomnia, the moodiness, the depression. That's starting years before their last period. And you're right. There needs to be, if you think about when I was educated, I was in medical school in the early 2000s. I went to medical school in 2000. I graduated medical school in 2006. So I remember 2002 in the WHI and what that did for menopause care. And I will honestly tell you, I learned almost nothing about hormones, how to manage hormones, that these symptoms could present in menopause. I was taught hot flashes and night sweats. That's what menopause is. I was never taught brain fog and mood changes and anxiety and insomnia were part of menopause or perimenopause. That's not something, it was new to me when I really went out and started to do this research a few years ago, thinking there's something, I'm missing a huge part of my ability to care for women because I didn't know this. And as I saw my mother transition and then me, and I just couldn't figure out what I was missing, a huge chunk, I felt, of my medical education. And also, I think it comes from this, a lot of medicine is now very siloed. So what I mean by that is people are hyper specialized. So they're doing rheumatology and psychiatry and, endocrinology, special interest in diabetes and cardiology. There are very few numbers of doctors that are truly what I would describe as generalists. And that GP, internal medicine generalist, has nearly become like a dirty word. Why would you see a generalist? You need to see a specialist. You would agree with that. That's kind of the perception. So when you end up in all of these different buckets, nobody's talking to each other. There's no cross talk between all of these people, and nobody gets the bigger picture.
That's terrible. And of course, the biggest loser is the patient.
Exactly.
So now tell me, how do you diagnose? How do you, or when does a woman voluntarily decide, oh, I'm going to go see a doctor about those symptoms? They may be, I may be menopausal, or I may be in perimenopause. Most people will think, my bones hurt, I'm going to go and see a rheumatoid arthritis doctor. Like you said, because everybody's so siloed, everybody wants to go see the specialist now.
Yeah.
So which women, or how would a woman feel that would you think should prompt her to go and see a generalist and talk about menopause?
So first of all, when it comes to perimenopause and menopause, let's talk about age. when can a woman present with symptoms of perimenopause? Really, perimenopause can start 10 years, 12 years before your last period. So if you think of on average, the average age of menopause is about age 50, and you subtract 10 to 12 years from that, I have women presenting with perimenopausal symptoms in their mid-30s.
Wow.
So from, I would say, mid-30s, women should start to think and be aware that, I might have some hormonal changes. So if they start to feel all of a sudden my periods are different, or I'm having difficulty sleeping, or so all of a sudden I have brain fog or anxiety, it's important that you talk to somebody that knows about menopause, that can say, it could very well be perimenopause, and what are we going to do about it? You bring up a second point. People love this idea of getting a diagnosis. How do I know for sure? With perimenopause, there's no way to know for sure. Your hormonal levels are changing every single day, hour to hour to hour. Your hormone profile is changing. So it's very difficult to pinpoint that somebody's in perimenopause. There's no test that will tell us that somebody's in perimenopause. So to make a diagnosis of perimenopause, one, somebody would be about the right age, so anywhere between 35 and 55, that they're presenting with symptoms like brain fog, insomnia, anxiety, mood changes, hot flashes, night sweats, joint pain. And also, I like to explain to people that, that sometimes the diagnosis is in the treatment. So sometimes if we say, well, I think it's perimenopause, and I think we should try some hormones, try some estrogen, progesterone, and see how you feel. And if you feel better, then that's the diagnosis. The diagnosis sometimes is in the treatment.
So it's a collection of symptoms that lead you on to. So is it a syndrome? Is menopause a syndrome?
I suppose menopause is a syndrome, yes. And that syndrome can vary widely from one person to the next. I have women that come and see me, and their biggest symptom is burning mouth syndrome, dry eye, tinnitus, vertigo, rashes. It can be just about anything. Could be a menopausal symptom. And that's because we have estrogen receptors on every cell in our body. Every part of our body has estrogen receptors. So loss of estrogen is not hot flashes and night sweats. It can affect every system in our body. And that varies, Yani, from you to me. Your symptom, was joint pain, and my symptom was itchy ears. It varies widely.
Yeah, I have the itchy ears too.
It's so frustrating.
The itchy ears, the dry eyes. You name it.
Yeah.
You said that you're not calling that everybody goes and gets HRT, but can everyone take HRT? There's a group of people who will worry about replacing hormones.
Mm-hmm. So the people that I would say have an absolute contraindication, so should not be taking HRT, are number one, women that are actively being treated for hormone-positive breast cancer. That's a no. That said, they can use vaginal estrogen, and we have some nice guidelines on that. But I'm talking about estrogen for the whole body. That group of people should not be taking hormone therapy. Number two, if you have undiagnosed vaginal bleeding. So if you have bleeding, heavy bleeding, intramenstrual bleeding that nobody has investigated or figured out, that person should not take HRT until that is resolved and they make sure that there's no underlying diagnosis there. In my opinion, those are the two absolute contraindications. People talk about clots. I'm worried, that I've had a history of clot. What's important to note about that is when you take estrogen orally, birth control, whatever form, or Premarin orally, when you take estrogen orally, there is a slight increase in our risk of clot. Me and you, as a background, our risk of a blood clot in the population is 1 to 2 in 1,000. When you give a woman oral estrogen of any form, that risk increases to 3 to 4 in 1,000. So it's a small increase, but it's an increase nonetheless. That's why we use estrogen through the skin, what we call transdermally. If you use estradiol transdermally, you do not increase a person's clot risk. So if somebody has a history of a clot or a clotting disorder, they are using estradiol through the skin is perfectly a reasonable thing to do and does not increase their risk of having a clot.
Why would anyone then take estrogen orally? Is there any advantage to that?
So some people hate putting it on their skin. That's
Really?
so
Yeah,
some people
I
really hate putting it on
empathize.
their skin. Yeah, they hate. There's 3 formulations that we have here. We have a patch, a gel, and a spray. And some people just hate the idea of putting it on. They find it easier to take it orally. Also, in this country, the estradiol orally is actually a lot cheaper than any of the other transdermal formulations. So that's another reason. Cost is another reason. And the third reason is everybody's different. So the way you absorb estrogen is going to be different than the way I absorb estrogen. And there's some people that just do not absorb it very well through the skin. And for those people, we might talk about oral, but we also might talk about intravaginal, which is a really nice approach as well. That's not oral.
Does that give the same effect? Intravaginal
Yeah.
gives the same effect as the gel?
As long as you use a high enough dose. So here we have a vaginal, 2 forms of vaginal rings. One of them is a very low dose called the E string, and it gives it's the same as using vaginal estrogen for the vagina. But we also have a product called FemRing, and FemRing is a ring that you wear, basically insert vaginally, that actually gives you a higher dose of estrogen. So it's similar to using a patch, a gel, or a spray.
And intravaginal, I think, is also important for avoiding IUDs.
UTI.
Not IUDs. UTIs.
UTIs. Yes. Yes.
That is me trying to be
Yeah.
technical.
And
no, but seriously.
Yeah. That's a very important point because a lot of women don't realize that our pelvic organs, so our vagina and our anus and our urethra and our bladder, all of those pelvic organs are very sensitive to hormonal changes. And they are very dependent on estrogen and testosterone for normal function. So when we lose estrogen, the actual tissue in our vagina changes. It goes from being very lubricated looking and very, very pink and very, very, it's kind of like I explain to people, when you examine a 22-year-old and you do a pelvic exam, the tissue, if you press on it, it bounces back. It's nice and pink. It's lubricated, kind of like skin, right?
Yeah,
But
yeah.
when a woman goes through menopause and you do a pelvic exam, when you touch it, it doesn't bounce back. When you touch it, it bleeds. So it loses a lot of its integrity. And unfortunately, if it loses its integrity, then it's pulling all your pelvic organs down with it. And it takes your bladder and your urethra with it. So women will present with pain with sexual intercourse. They'll present with UTI symptoms, UTIs, recurrent UTIs. And I can't tell you the number of women that I see that are taking antibiotics every single day, chronically, for their UTIs. And nobody has offered them such a very simple intervention that is potentially life-changing. And I've spent a lot of time in primary care taking care of older people. And the recurrent UTIs, women ending up with sepsis, they're in the ICU with their UTI sepsis and dying because nobody bothered to give them a little bit of vaginal estrogen. It's just tragic.
Does the estrogen reverse how the vaginal tissue?
It does. Yeah, it's really fascinating. Yeah, because if you do an exam and watch it over time, you will see. It's funny. I met a gynecologist when I was in London recently, and she said, your age is reflected in your vagina, right? It is. Wow. Yeah, you can really tell somebody's age by the way their vagina appears. So you can restore function with low dose vaginal estradiol. Yes.
That's very interesting. So when we talk about hormone replacement, we talked about the estrogen. The progesterone is very important to, I understand, protect the womb. Is that the only function?
So it has 2 main functions for progesterone. The first one is protecting the womb. So I like to describe it as estrogen is like the fertilizer for the womb, and progesterone is the lawnmower. So it keeps the uterine lining nice and thin. Because if we don't do that, then the uterine lining gets thin. You can have bleeding. You can develop, polyps and fibroid. We don't want any of that. That's bad. So for a woman that has a uterus, we must give her progesterone. But equally, progesterone is one of our hormones in our body that keeps us calm. It helps us to sleep. It is our stress management hormone. It manages our anger. It manages our rage. So I see women, especially in early perimenopause, and often the first symptoms that they have are the low progesterone symptoms. So they come to see me and they say, I am so angry with my husband. I am just shouting at my children. I get so worked up over stupid things. I don't understand why I'm so irritable and reactive. And that's because of progesterone.
Interesting. Right. Yes, and yes to all
Yes.
to the whole list that you get, and then after that period in your life as a woman, you find that you have to repair now all
And
those
all your
relationships.
relationships. 100%.
Yeah.
I can't tell you about the number of women that I've seen that have come in to see me, and I've started them on treatment, and they're maybe in their late 50s, and they've come back to me, for their follow-up 8 weeks later, and they've said, I regret leaving my job. I regret, had the fractured relationship I now have with my husband. I regret my divorce. I've had people
Yeah.
say, it's so
Wow.
sad.
It is very sad. It is truly sad and avoidable. And that's
Yes.
that's the thing. Now, what about testosterone then?
Yeah.
What's testosterone and why?
Yeah, I love testosterone. So when we talk about our sex hormones, we're talking about estrogen, progesterone, and testosterone. Testosterone is a very important hormone in women and in men. So if you imagine in a 22-year-old premenopausal female, she has 5 times the concentration of testosterone than she does to estrogen. So she actually has a lot more testosterone in her bloodstream than she does estrogen. Unfortunately, when they described these hormones a long time ago now, they what we call sexed them. They called testosterone, which comes from the testes, which gave everybody the impression that this was a male hormone, which is not
Sure.
true. Women have testosterone, estrogen, and progesterone, and men have testosterone, estrogen, and progesterone. We all have these hormones, just in different concentrations. So men will have a lot more testosterone than us, but that doesn't mean that we don't have significant amount of testosterone. And testosterone has a lot of the same effects on the body as estrogen. It's important for our metabolic health. It's important for our brain fog. It's important for muscle mass, bone density, libido. And I love to use testosterone. What I often do when I'm treating women is I start with the estrogen and progesterone, do that for a couple of months, see how people feel, and then I will add the testosterone later. Kind of in a way, I describe it as papering over the cracks. So we get a lot done with the estrogen and progesterone, and then we paper over the cracks, the additional benefit that we can get from using testosterone for their brain fog, for their mood, for their motivation, for their sleep.
Right. I was prescribed DHEA,
Mm-hmm.
which I understood would promote the production of testosterone. So that's not the same thing.
No. So DHEA, so if you think about how we make estradiol in our body, it starts as a cholesterol. All hormones start as a cholesterol. Most hormones start as a cholesterol. So it starts as a cholesterol, and then it's changed over time until it reaches estradiol at the end. If you back up one step, you have testosterone. So we actually make our estradiol from testosterone. If you back up another step, you get DHEA. So when we're manufacturing these hormones in our body, we get to DHEA, then we change DHEA to testosterone, then we change testosterone to estradiol. So when people give you DHEA, they're hoping that your body will change that into testosterone. My feeling on that is if we want you to have testosterone, we should just give you some testosterone, because I don't know in your body how much of that you're actually going to change into testosterone. We're dependent on an enzyme in your body making that change for us, when we can actually just give you the testosterone that you need.
We're putting all these back into the body.
Mm-hmm.
Is there, and I have to ask, is there a natural alternative? If I were to live a healthy lifestyle, if I were to eat certain foods, take certain supplements, is that going to give me close enough results? Probably, maybe not 100%, but how good is that?
So for your menopausal symptoms, you are not going to get resolution of your symptoms with supplements and lifestyle. If we're talking about your brain fog and your hot flashes and your night sweats and your mood disturbance, the standard of care to improve those symptoms is hormone therapy. That said, I have a dietitian on staff. I partner with a weightlifting gym. I have a meditation specialist that works for me. All of those lifestyle things are really important, right? Because HRT is only one spoke of the wheel when we think about our health. HRT is one spoke: diet, nutrition, exercise. stress management, sleep. All of these are really important for our overall health and to make sure that we can be the best that we can long term and we're not fracturing and falling. But you cannot get the same benefit from any supplement or lifestyle modification as you will for your symptoms with hormones.
If you were to assign priority to all these that you just mentioned, the sleep, the nutrition, the exercise, the meditation, if you were to put them on a list, could you? Or are
Oh,
they?
they're
Are
all
they?
really important.
I'm sure.
Yeah, I would have a hard time with that. I think they're all equally important because, for example, sleep. People don't, all of these things are so interchangeable. People have this idea, stress management, sleep. Oh, it's because of my mental health. Actually, yes, it's because of your mental health. But if you don't sleep or you're stressed, that has physical changes in your body. Your body is responding in a stress reaction and actually will therefore increase your blood sugar, increase your inflammatory response. So if you were, for example, I have people wear continuous glucose monitors, so what we call a CGM, if I'm worried about their blood sugars, and they'll come back and they'll say to me, oh my goodness, I got stressed. I had an argument with my such and such, and my blood sugar went up. And I said, yeah, if you're stressed, it actually causes physiological changes that happen in your body. And that has long-term effects because if you're stressed and therefore your blood sugar is high long-term, that's a problem for your long-term health. That's a problem for your risk of cardiac disease. That's a problem for your risk of type 2 diabetes. So those people have this idea when I talk to them about seeing my meditation specialist. But I'm like, no, this is really important for your health. I can see it in the numbers.
Yes. So all these disease or conditions that you mentioned, the diabetes, the heart, etc., that's the metabolic or high cholesterol. That's the metabolic syndrome. In fact, that was one of the first things that got me thinking about that there must be something that connects all these women that I'm seeing, my mother, my aunts, older neighbors. They all somehow had high cholesterol. They all had that big belly. They all had
Sukkar, all of them, everything.
insulin resistance. So what is it that connects all these women?
Yeah, let's talk about it. So what you're talking about is the metabolic syndrome of menopause. This was a recent term coined by Dr. Mary Claire Haver. She's a doctor here, a gynecologist in the space here in the US. And what is the metabolic syndrome of menopause? Why does it happen? So to understand why it happens, you need to understand that estrogen is very important for our metabolic health. Okay, so estrogen and insulin are closely linked in function. So what is insulin? Insulin is a hormone that is released by our pancreas in our abdomen in response to a rising blood sugar. So you eat an apple, your blood glucose rises, your pancreas releases insulin. Insulin goes all over the body, binds the insulin receptor, opening a channel, allowing the glucose to flow from the blood into the cell to make energy. Me and you are making energy right now from glucose. As a result, our blood sugar level comes down and order is restored. So that's what's happening in a very normal situation when you eat an apple. What happens when we lose estrogen is we become insulin resistant. What is that? So now you eat an apple, your blood glucose rises, your pancreas detects that, it releases insulin, everything's going great, this is how it's supposed to happen, but nothing changes. So it releases more insulin. So it releases more and more. Now you need more insulin for that one apple than you did 10 years ago. This is what we describe as insulin resistance. So nobody in the body is listening to the insulin. Why is that a problem? Because the higher your insulin level is, the more fat you will deposit, particularly visceral fat in our abdomen. And the problem with that visceral fat is it is what we call metabolically active. It's going to drive up our cholesterol. It's going to drive up our blood pressure. And collectively, we call that metabolic syndrome. And that's why women go from having a very low risk of cardiac heart disease in their 30s to a very high risk in their 50s. And it's a very quick increase because of this metabolic syndrome. So, and that presents with type 2 diabetes, and their cholesterol is high and they get heart disease, and all of those it's all part of the same syndrome.
you mentioned earlier, we talked about who can not or should not take HRT, and you said women who are being treated for actively being treated for breast cancer. And what about other cancers, or what about a cancer in the family?
So family history of breast cancer is not, or any cancer is not a contraindication to taking hormone therapy. This is a conversation that I have routinely in my office, that having a family history of breast cancer does not preclude you from taking HRT. It's important that you do your prevention, all of us. It's important that we're all, getting our colonoscopies for our colon cancer screenings, that we're all doing our mammograms, that we're having our pap smears. It's important that we utilize all those tools to get our screenings to decrease our risk or for early detection of any kind of cancer. But having a family history of cancer does not preclude you from taking HRT. And in fact, one of the very interesting findings from the WHI was that it appears that hormone therapy may decrease your risk of colon cancer. And could that be part of the anti-inflammatory picture, part of the metabolic picture? All of these things all of our organs are not separate. They all live in the same environment of our body. So when we have changes in one area of our body, it's likely that there are changes happening elsewhere. So when you think of what the underlying issue with cancer is, it's an immune problem. Your body hasn't been able to get rid of these cells or whatever is happening that's causing the cancer. It's often a metabolic problem. And all of those problems we know happen in menopause. So the loss, that kind of disequilibrium that happens because of menopause probably overall increases our risk of cancers.
So what sort of screenings should women undertake? Because I know in our part of the world, unfortunately, most healthcare is still private. Unfortunately, there isn't that much awareness or screening callbacks for screenings and so on. What sort of screenings should a woman do?
So there are 4 overall screenings that I want all women to do. The first one is having a pap smear. So screening for cervical cancer. So the cervix is at the bottom of our uterus, the rahim, right? And it's very easy to screen for that type of cancer. Now that should start from age 21 until age 65 is generally what they say for cervical cancer. That's what exists. That's the way that the guidelines are written here. So from age 21 to age 65, you should be having regular pap smears. And often we say every 3 to 5 years, depending on your risk and whether you've had an abnormal pap smear. So that's one thing. Having a quick pelvic exam and a pap smear is really important to decrease your risk of developing cervical cancer that is untreatable. The second one is having a mammogram. So a mammogram are x-rays of your breasts to look for any signs of breast cancer. Now that should start at age 40 and happen every 1 to 2 years after that. Here in the US, we say until the guidelines say until age 75. I think that that's debatable. A lot of people go further than that. So pap smears, mammograms. The third one is bone density scans or DEXA scans. So I don't know if you know this, but in the Gulf countries, women do not have good bone density compared to people of Anglo-Saxon descent and people in the U.S. So Middle Eastern women do not have good bone density. So they are at very high risk of fracture.
Is that, let me just interrupt there, is that because of the nature we live in? Is because sun? Is it, what's it?
I think mostly it's genetic. Actually, one of the big risk factors for having loss of bone density or osteoporosis is actually a genetic marker. So having a parent that has had osteoporosis. So I think that that's mostly the case. You could argue for, even though it's a very, very sunny environment, a lot of people don't go outside, and they're not in the sun. So are we decreasing our exposure to vitamin D? And then the third one is exercise. So are we all doing a lot of weight-bearing exercise, weightlifting? Probably not on average. So I would say the most likely cause is the genetic cause, but I think the other things definitely play into it. So what is a DEXA scan? A DEXA scan is it's a X-ray, basically. You lay down and they look at your spine and they look at our hips and they look at our non-dominant forearm. And they compare the pictures to somebody that's younger than us to see how much loss of bone density there has been. It's important that we know that so that we know what our risk is of developing osteoporosis and having a fracture. And also, if you can catch it early enough, we can treat it.
Amazing. And the fourth screening?
Fourth screening is a colonoscopy. So again, colon cancer is on the rise across the globe. There are huge risk of colon cancer in the Middle East. It is important that we know your risk. So if you have a family member that has had colon cancer, then you should start with early screenings. And that is 10 years before their cancer is diagnosed in terms of age or at age 40. So if you have a family member that has had colon cancer, you should be starting your colon cancer screenings at age 40. If you do not have any family member that has had colon cancer, you should be starting colon cancer screenings at age 45. And then depending on the findings, you will have a recall, whether that's 3, 5, or 10 years, depending on your risk.
Noor, I'm going to ask you to kindly help me advocate for HRT and for more screenings in the environment that we live in, where, like I said, most healthcare is private and there is nothing that is mandatory to ask women. So women need to take responsibility for themselves. Nobody's looking out for them except themselves. How do we convince them? What is the argument that we can present that is going to make them not miss this beat?
I think it's this understanding. I think menopause has been relegated to hot flashes and night sweat.
Yeah.
I think people need to understand that when you lose estrogen, all of these changes are happening in your body. So your sukkar has a lot to do with your estrogen. Your cholesterol has a lot to do with your estrogen. Your loss of bone density and your bone pain and your joint pain has a lot to do with your estrogen. I think when we start to educate women that all of these things have to do with menopause, that's going to spur them on, because it's not just, they're actually motivated to deal with their type 2 diabetes. They're motivated to deal with their cholesterol. They're motivated to deal with their recurrent UTIs, right? But if they don't realize that all of that is part of the menopausal syndrome, and if we can help people, educate people to make sure that they understand that all of those things are connected to estrogen, then you start to have the conversation and people are like, wait a minute, maybe I need that to help with all of these X, Y, and Z's that I'm having.
And all those screenings and all those tests and all those hormones to buy are quite expensive, not just in my part of the world, but everywhere in the world. Why are they so expensive, and when are they going to get cheaper, as it were?
That's a great question. So one of the issues that we have with estrogen is access and cost, or our hormones here. And the reason for that is because they cannot patent a hormone product that exists naturally. So estradiol that I prescribe is the same estradiol that I make in my body. The progesterone that I prescribe is the same progesterone that I make in my body. The testosterone is the same testosterone that I make in my body. So unfortunately, we live in a very capitalist environment. And if people can't make money, the pharmaceutical companies or generic manufacturers can't make money, they're not going to make it. So what we have is a situation where actually estradiol, they're not able to make a lot of money on these products because they cannot patent the product. And so we are kind of monkey in the middle. And so the change to that really needs to come from the governmental level, and what the push is to get access to these at a reasonable price.
And then what is it that we are buying? What kind of hormone replacement therapy should we go for? I know that I use a gel that I buy. I can buy at a pharmacy. It's prepackaged. It's done. It's something that I can buy in many different outlets. Other people or other doctors would prescribe hormones that need to be compounded so that they match the body. I mean, is there truth to that? Is there some reason why I should go for something that's bespoke rather than something that is ready-made?
So that's a great question. So compounding. Well, let's define what compounding is. So a compounding pharmacy is a pharmacy that makes medication, manufactures them to order for a patient in a certain concentration. Now, there are a lot of practitioners that like to use compounding pharmacies. Now, the I do use compounding pharmacies on occasion. Most people do great on the estradiol gel, like you've described, or the patch, or the spray, which are approved by the FDA. They are cheap and they're easy to get. Compounded products often are expensive and are hard to get. So I will use a compounded product if I have a person, for example, some people, Siba, like you know, will react to the gel. There's something in it and they will have an allergic reaction on their skin and they just can't tolerate any of the forms. So that person, I will go to a compounding pharmacy. I'll talk to them. I'll say, my patient is, reacting to everything that's available in the market. We need to make something different that she's not going to react to. That's a good reason to go to a compounding pharmacy. But this belief that somehow what you get from a compounding pharmacy is more natural, it is not. It is exactly as natural as what you get from the pharmacy, that it's somehow better for you. It is not. It is the same product, maybe in a little bit of a different concentration, which we can do by having you have more gel or less gel. So there's no reason for the average person to need a compounded product.
I mean, that was definitely something that needed clarifying. And also, do I need to go through expensive tests to decide that you need to prescribe me HRT?
Again, no, because there is no test. There's no test that's going to say for sure you're perimenopausal or menopausal. I can tell by looking at you, by your age, the symptoms that you have, whether or not you're likely perimenopausal or menopausal. I do like to do some tests for patients as baseline. Let's see what your blood sugar is, your cholesterol, all that sort of thing. But that's not what I need to diagnose perimenopause or menopause. All I need is listen to your story and decide together if we think you're in perimenopause and menopause. And if we do, then I would offer treatment.
And how do you adjust the dose then? Do you do a blood test to figure out the level of hormones in the body, and then you can increase or decrease whatever you prescribed me?
So don't forget that in perimenopause, your hormones are going to be all over the place. So using your hormones as a guide is not useful in perimenopause. I use your symptoms as a guide. So I generally start people on the kind of lower end of the spectrum in terms of dose, and then I see how they feel, and we very gradually creep the dose until they feel better. In a woman that's postmenopausal, so she's run out of eggs, her ovaries have stopped working, she's not making any estrogen or progesterone, then doing levels is a lot more useful because the levels are actually going to reflect how much she's absorbing of the estrogen. But in a perimenopausal female, there's nothing really to be gained. I do them because they're, useful over time to track, but I'm not using them as a guide for treatment.
Right. And another myth that perhaps you could bust for me, or maybe confirm, maybe I think it's a myth, is that a lot of people will think that, I'm going through, okay, I'm perimenopausal, I'm menopausal now, and then that's going to end in a couple of years. How many years does a woman stay in menopause? That syndrome, like we
there's
call
this
it.
word, there's this kind of like creep of this word where they've used menopause to define one day in your life when you are a year without a period, and then they've described postmenopause. I disagree with that. You're in menopause for the rest of your life. You do not have estrogen and progesterone for the rest of your life. In terms of symptoms, we often see over the next 3 to 5 years after menopause that, for example, hot flashes get better. Some people feel their sleep improves. Some people feel there's a little bit of an improvement in their brain fog. That's variable. I see women in their 80s that are still having hot flashes. So there's huge variability in whether or not your menopausal symptoms will get better after menopause or not. So this idea that it's all going to get better and it's going to go away in terms of symptoms is very variable. But it's also really important that we're not just talking about symptoms. We're talking about your risk of chronic disease. So you will continue to increase your risk of cardiovascular disease. You will continue to increase your risk of type 2 diabetes. You will continue to increase your risk of an osteoporotic bone fracture, whether or not you're having symptoms every year that passes without estrogen.
As women are finding out about this now, how late can a woman start on HRT? I mean, a woman in her 60s, a woman in her 70s, can she start on HRT?
$1 million question. So I will say in my practice, I routinely start women in their 70s on HRT.
Wow.
When you look at a lot of the data, people talk about this idea of the 10-year window. Have you heard that before?
Yes.
So this 10-year window really came from the WHI. We've come full circle to the first study that we talked about. One of the findings of the WHI was that they found that they said that hormone therapy increased your risk of heart attacks and strokes. That's what they said. What they actually found in the data is that if you initiate hormone therapy within 10 years of a woman going through menopause, so within 10 years of her last period, you decrease her risk of cardiovascular disease by about 30%. That's huge. There's no drug that does that, right? So if we initiate hormone therapy within that 10 years, we decrease a woman's cardiovascular risk by about 30%. If you initiate after the 10 years, you do not have the same preventative benefit. And we think it's because the woman has already likely developed some cardiovascular changes in her arteries. And we can't walk that back. We can't undo that change. What they showed is that what they hypothesized is that oral Premarin, we know oral estrogen increases our clot risk, right? So they took women that were over 10 years from menopause and they gave them oral Premarin, which increased their clot risk. So they clotted. I'm not that surprised. Some of them did, very small number. So it's not that surprising, but that's not what we do. We use transdermal estrogen and we use transdermal estradiol. We know that that does not carry a clot risk. So when you compare the two things of what they did in the WHI and what we do now, it's comparing apples with oranges. It's not the same thing. So from my perspective, if you are looking to start HRT, the earlier the better. But if you are outside of the 10-year window, you probably aren't going to get the same preventative benefit for your cardiovascular system, but we can still protect your genitourinary system, decrease your risk of UTIs. We can still improve your brain function. We can still decrease your risk of type 2 diabetes. We can still improve your bone density and decrease your risk of fracture. So there's all these other benefits to be had, even if you start later in life.
That's amazing. That's wonderful to know. And once you start on HRT, how long do you stay on it?
So I generally tell people for life, unless you develop a contraindication. Some of us will get breast cancer. That's just how life goes. And so if you get an estrogen positive breast cancer, we will have to stop your HRT. And I have had some people where we found I've talked to the oncologist and we've come up with a solution in the meantime while they're having their treatment. And that's okay. But otherwise, for life, there's an interesting Finnish study that was done after the WHI, where in Finland, they have this amazing biobank where they follow the whole population from a medical perspective. And what they showed was in women after the WHI, with the sudden stop in HRT, there was a huge increase in number of cardiac events in women. Huge increase. So we know that if you stop the HRT, all these things start to happen, right? You start to lose the bone density. You start to increase your risk of cardiovascular disease. So to retain the benefit of taking HRT, you need to stay on it.
And how consistent should you be with taking your hormones, with applying your gel, with taking your progesterone and the testosterone?
As consistent as you can be. We want to achieve a steady state in your hormones. We want your hormones to be the same day by day by day, instead of having big fluctuations in your hormones, because often when a person has a dip in their hormones, they haven't taken their estrogen or whatever they've done, they'll feel a return of some of their symptoms. They'll feel it. So as consistent as you can possibly be, I tell people, try to, make it part of your normal. Like I use Eva Mist spray and it's beside my toothbrush and I brush my teeth and I do my Eva Mist spray. So it's trying to build it into your day-to-day habits so that you can remember and make sure you do it every day.
Go back and talk a little bit about eggs and talk about fertility of women. So younger women who are worried about, how long can a woman wait before she starts to think about, I may be finishing my eggs, as it were, since we said that a woman is born with the eggs that she's going to have for her entire lifetime.
Yeah.
And women want to be to have the option of what fertility gives them.
I would say there's two things at play here. Number one is the number, so losing overall a number of our eggs, but also the egg quality. The way that we use and release our eggs throughout our reproductive life is that we actually release our higher quality eggs early. So when we get to closer to perimenopause, we're making some eggs, but they're of lesser quality. So when we talk about fertility, we probably need to be making some sort of decision or plan before 35. And so, I really encourage people, to talk about egg freezing. If that's something that conversation that you want to have, see a fertility specialist, have a conversation. If it's something that's, you're worried about, that you don't feel that you're in a situation that you can have a pregnancy, talk about egg freezing. It's an option, right? It's an option to use those better quality eggs and freeze them so that they're available to you later on in your life. And that's a conversation to have. But if you really are thinking about from a fertility perspective, from our body and how our body will respond and the quality of our eggs and the ease with which we can get pregnant, having that conversation probably before 35 is most appropriate.
Fantastic. So can we, in conclusion, just a very big and wide question is, now that we know, can a young woman prepare for menopause?
Yeah.
And how?
Knowledge. If you know what it is and you understand what it is, you have an understanding of what's happening in your body and the symptoms that can possibly happen, then when you start to see those symptoms, you can recognize them. Too often what we're seeing, similar to you, Siva, is that you're going through 10 years of misery and you don't actually know what's happening, right? So knowledge and education early. So the same as we teach women, about girls about puberty and getting their first period, we should equally be having that conversation maybe a little bit later in their life about perimenopause and menopause, what it is, how you're in it, what is happening in your body, so that when you're in it, you can recognize it and you're like, okay, I know what this is, because knowledge is power, and you can ask for help then. If you know that what help to ask for.
So are you finding that women are coming forward more? Are you finding younger women coming into your practice, asking the questions, finding help for themselves?
100%. And I think really social media has been really laid the ground for this, because I think that's how the word has gotten out about what is perimenopause, what is menopause, because a lot of these women have been seeing their primary care physician or their rheumatologist, and nobody has said the word hormones to them, and they've seen it on social media. So I get a lot of people that see me on social media and come in and see me to have a conversation about their symptoms and how they're feeling. So that would be, I would say, where a lot of people are really getting a lot of their knowledge from. And it's some great knowledge out there on social.
And this is when we stop and we are thankful for social media for once, as opposed to it being the big villain. Yeah. It's unfortunate that the stigma continues. It's unfortunate that we still find it difficult to talk about these things. And it's unfortunate that women are still seen as, these weird creatures that have a certain way of being once they get to a certain time in their lives, and they have to be managed, as opposed to, here's a collection of symptoms. This is a syndrome. Irritable bowel syndrome is dealt with. Down syndrome is dealt with. But this particular syndrome somehow remains taboo, and something that a lot of the time will not be acknowledged even.
And because it's hard to do, treating, there's no guideline, like you do this and then you give her this and then you give her this and you do this dose and then you're good. And with diabetes, for example, we check your blood sugar, we change your medication, we check your blood sugar. Oh, you're better. That's great. With menopause and perimenopause, that's not how we do. You have to listen. It's a lot of patient interaction. It's a lot of empathy and compassion. It's a lot of what I describe as shared decision making between you and the patient. And that takes time and investment, both from the point of view of the doctor, but also from the point of view of the patient.
So the big question is, what doctor shall I go to? When I have these symptoms, I've read a couple of Instagram posts, and I've seen one or two documentaries. Now, who do I go to? Who's going to help me? Who's going to sit with me, understand me, and give me the time of day?
So that could be really anybody, because it could be a urologist, for example, that has an understanding, or it could be a gynecologist that has an understanding, or it could be a primary care doctor that has an understanding. What I would suggest is when you call the office, you ask, does this provider or practitioner, do they prescribe HRT? Do they deal with menopausal symptoms? Don't wait until you've paid the money and you've taken the time off work and you've done all the things and you're in the appointment and you find out that this is not something that they do. So I would say preempt the question ahead of time. Ask your friends. Here in the US, we do have some databases where you can actually search when other people have had good experiences, they put the person's name into the database so it's searchable by location. That's useful, but ask people, are you on, who have you seen? And call the practice before and see to make sure that they do it, and don't waste your time.
Noor, thank you so much
Welcome.
for giving us your time. I know how precious that is. And I really look forward to receiving you in Dubai next time you pass through the region.
I would love to.
Thank you for your time.
Take care. Bye-bye.
And for the great insights.
Thank
and
you.
for your fantastic work.
Thank you. Have a wonderful day.
يمكن كلنا مرقنا بوقت قلنا فيه إنه خلص هيك جسمي وأنا كبرت وصار بدي أتأقلم مع الموضوع. بس الحقيقة إنه مش ضروري إنه نستسلم لهالأفكار. العلم اليوم عم يشتغل لصالحنا والحلول صارت موجودة، بس لازم نعرفها ولازم نطالب فيها ولازم نسمح لنفسنا، وهذا الأهم، إنه نعيش بصحة وراحة وتوازن، مش بس بأول 30 أو 40 سنة من عمرنا، لكن طول حياتنا. إذا عجبتكم هذه الحلقة فيكن تتابعوا كمان حلقات عن الموضوع، عن صحة المرأة، موجودين على البلاي ليست لبودكاست تحت الهواء مع السبا عودي. وكمان في حلقتين عن الصحة واللايف ستايل ما لازم تفوتون، ودكتور نور موجودة على انستغرام Ask دكتور نور. كل الروابط بتلاقوها تحت هاي الحلقة. ما تنسوا تعملوا سبسكرايب وتشاركوا الحلقة مع سيدات بهمكن أمرهم، وقولوا لنا بالتعليقات شو أكتر شيء لمسكن بهذه الحلقة. بالحلقة الجاي نشوفكم إن شاء الله، وكل حلقة وإنتوا أغنى.